because we have a system in the United States, a healthcare system that's completely and perfectly designed to yield the results that we are getting today. It's a system that was built on the experimentation and exploitation of humans, marginalized humans in our society.
Hello, everyone. I'm Angela Rosa DiDonato.
And I'm Marian Leary.
And you're listening to Amplify Nursing, a Penn nursing podcast supported by the Pinola Fund for Innovation in Nursing.
Amplify Nursing features nurses who are leading the way in science, policy, and innovation.
Our guests defy stereotypes, define practice, and disrupt convention.
We highlight the breadth and depth of nursing influence on society by amplifying nurses who are pushing boundaries and breaking down barriers to build a new paradigm. This week, on our next special COVID-19 episode of Amplify Nursing, we talk with Dr. Sascha James-Conterelli. Whether leading the New York State Association of Licensed Midwives or teaching at the Yale School of Nursing, Dr. James-Conterelli is bringing to light racial disparities in maternal morbidity and mortality. As co-chair of Governor Cuomo's Maternal Morbidity and Racial Disparity Task Force, she's using her experience to create policy change at a state and national level. We talk with her about her policy work, the added changes COVID-19 is placing on marginalized communities, and the need to be optimistic about the future.
Dr. James-Conterelli, thank you so much for coming to speak with us today.
Thank you very much for inviting me.
Yeah, it's a pleasure to have you. So why don't you tell us a little bit about yourself and what you study?
Okay, thank you. My name is Sascha James-Conterelli, and I'm a midwife. I'm also the president of New York State Association of Licensed Midwives. I'm currently faculty at Yale School of Nursing at Yale University. I focus mainly on, primarily on women's health and women's health issues, but my main area of interest for research has been maternal mortality and racial disparities. So in that vein, I co-chaired, I was one of the co-chairs of Governor Cuomo's Maternal Mortality and Racial Disparities Task Force in New York State, which made recommendations for the governor to begin to address and tackle the crisis that we have in New York related to maternal mortality and racial disparities. I've also recently been on the Governor Cuomo's COVID-19 Maternity Task Force, looking specifically at issues related to maternal health during the pandemic.
So you're busy.
Yeah.
So for those who aren't aware, can you talk to us a little bit about what exactly we mean when we say disparities in maternal morbidity and mortality?
So in the United States, beyond having a high maternal death rate in the United States of about 26.1 humans per 100,000 birthing people dying in the process of having a baby or after having a baby. We also have a great discrepancy in the types of people that are affected by maternal mortality and severe maternal morbidity. And what I mean when I speak about maternal morbidity, meaning the sequelae or issues that can be surrounding having a baby, such as having a hemorrhage, having an infection, needing alternative surgeries or therapies, or having diabetes and high blood pressure in the instance of pregnancy and after childbirth. So the disproportionate effects for these issues are seen more in your Black and brown women in the United States. So Black people especially have a largely higher rate of maternal mortality and severe maternal morbidity than compared to their white counterparts of lesser education. So, for instance, in New York City in and of itself, so the five boroughs that everybody likes to go visit, when you think of New York City and bright lights and big city, you have black women having an 8 times higher rate than an educated, college educated black woman, an 8 times higher rate of dying related to pregnancy and childbirth as compared to a white woman with a high school education.
Wow. That's,
And in the country, yeah. And in the
yeah.
country, in the United States, you have black women with a college education having a 3 to 4 times higher rate than a white woman with a high school education of dying related to pregnancy and childbirth. So in the
Wow.
past, we had these myths that um, getting educated and having access to good health care, or what we perceive as good health care, was protective against adverse effects in health, right?
Right.
If I have access, if I'm educated and I'm well informed, then I can, and I work hard and I have a good job, I can access good health insurance and access preventative care that would decrease my risk of diabetes, high blood pressure, um, and dying, right, essentially.
Right.
And if I am educated and informed, I'd have a better diet. I can pursue all the wonderful opportunities that we have in the United States, a good home, clean air, good food, but not for black women in the United States. There's no protective effect of education nor socioeconomic status. Actually, what we see is converse to that, the complete opposite. The more educated you are and the more you have access to opportunities in the United States, the higher your risk is of actually succumbing to an, a comorbidity related to pregnancy and having a child.
So why do we think that is?
So, what we've noticed and what we've known for a long time and been afraid to admit, and I'm actually happy that we're studying it now, is the long-term effects of racism and oppression and discrimination in the United States and the toll that has on the human body. So now we're actually seeing evidence and research focus on the generational effects of slavery, of racism, of discrimination, of oppression of people.
So what kind of recommendations have you made in order to combat this problem?
So I'm glad you asked that question. So this is a multimodal or multi-pronged effect and strategies that we are developing locally and actually nationwide, because this is not something that came about overnight and or within the last 10 years. This is hundreds of years in the making. And so for that reason, we have to look at the systems that are in place and begin to address the issues within the systems that are already established. So, for instance, one of the things that I've been involved in is the CDC recently had a work group to look at our extrapolation form that's standardized across the United States for maternal death. It's the maternal mortality review abstraction form, also commonly called the Maria form. And so a task force was developed in order to look at that extrapolation form and begin to insert tools and options for those extrapolating and really reviewing maternal deaths to identify areas of discrimination, areas of racism that may have led to unequal treatment or communication that may have contributed to a maternal death. So we successfully did that just recently, and that form was recently updated and rolled out. So that when you're in another state and you have a maternal mortality review committee, really looking at a maternal death, and uh, there's areas of communication that can be identified, or missed opportunities, or lags in care, or cultural insensitivity, or lack of cultural humility. Uh, those are categories that we can capture now that may have contributed to a maternal death, where you would have decrease in access to healthcare, lag in treatment plans, lag in the initiation of communication with family and family members, that would lead to someone's demise. Uh, so other than that, so we know that maternal mortality is just the tip of the iceberg. Underneath that, and that's where you get to the severe maternal morbidity, where you have multiple people that are suffering, that are what we call near misses. So they survive maybe in spite of all of our care, in that maybe they have a severe maternal hemorrhage, or hypertension that was uncontrolled, or diabetes that was uncontrolled. And they survive this pregnancy and survive the birth, but they still are walking around being affected by that entire process of pregnancy and birth, and not being fully aware of what really happened to their body, and whether or not, if they get pregnant again, would that happen again, and could it lead to even more detrimental effects to them, and possibly a death. So severe maternal morbidity is something that we really want to look at in order to cause a shift and make a shift and really truly affect and decrease maternal mortality that we're seeing.
Yeah, that seems like a daunting task, considering all of the things that are going into it.
Oh, yeah, because we have a system in the United States, a healthcare system that's completely and perfectly designed to yield the results that we are getting today. It's a system that was built on the experimentation and exploitation of humans, marginalized humans in our society, for the betterment of the majority. And so the majority being white people, your marginalized humans in this country, and we've known this through evidence such as the Tuskegee experiment, for many, many years, were utilized in order to advance research and technology in the healthcare field. Why Marion Sims' statue was removed from Central Park, right? We've advanced in healthcare, yes. However, while continuing to marginalize and experiment on members of our society that don't have a voice, really.
Right. So how has this current pandemic compounded the issues that we are already having?
So you use a perfect word, compounded the issues. So it just underscores. So what we're seeing is within communities of color, so in Black and Hispanic communities and your marginalized communities, you see more effects of COVID-19, right? And where you see that and why that manifests is, number one, again, because those members of your society are used to being oppressed, are used to being afraid of the already healthcare system that's in place, you see a lack in access to care, a delay in access to care, and because the marginalized members of our community are the forgotten members you saw the decrease in supplies and efforts being applied to those parts of the communities that are most effective. So a disproportionate amount of things such as personal protective equipment, point of care testing or testing on points of entry to hospital, those areas that really, those hospitals and institutions that service communities with mainly Black and brown people were some of the last communities to have a distribution of PPE or personal protective equipment for your healthcare workers in that area. Were the last ones to get what we call point of care testing or testing, access to testing for all members that were coming into those facilities. A delay in the processing of the testing. So then it just underscores what we already know about healthcare in this country for Black and brown members of your community members.
Yeah, I think that, this pandemic is highlighting many of the gaps that we have all over the place, but it's been really incredible to see how much the pandemic is highlighting the disparities that we have in our healthcare system. And I'm hoping, not to say that this is a good thing to come out, that it would be a good thing to have a pandemic, but if it highlights this to the point where it can no longer be ignored, then I have to say I think it's probably a good thing that we're able to see this so apparently. I'm sure that's frustrating for you because it's something that's been apparent to you for a long time, considering this is what you've been looking at and studying. But when it gets to the point that it's so blatant in the public consciousness, I feel like there's no other choice but to do something about it, and change it for the better.
Well, you and I are both optimistic. Not everyone is optimistic. And again, what you're saying is absolutely correct. Not that we would want a pandemic, not that I like being in the middle of a pandemic or the effects of it, and nor would I ever want any human to perish related to something so tragic as this, or in any way. I don't wish that on anyone or any member of this society. However, if the members of this society that lost their lives related to this pandemic, if we can provide justice for their death, would be for us to utilize this opportunity to have a better society, to be better prepared for, God forbid, another pandemic in many areas, from education on up, right? To be better prepared for the long-term effects of a pandemic, and to address some of the issues that we knew were already bubbling, but now are being definitely brought to the forefront, and as you said, are glaring and should not be ignored. Of course, as humans, we can ignore whatever we want to ignore.
Yeah.
What we would hope is that we do not, and we learn, and we become a better society because of it.
Right. That's kind of what I'm hoping for. But I am a little bit of a pathological optimist for sure.
Me too.
Anyway, so for those of us who are, I am in clinical practice. I do quite a bit of OB anesthesia. What are some of the things that as clinicians we can do at the bedside to offset some of the negative effects that we already know are built into the system?
Oh, great question. And that's something that everybody can do, and not only clinicians, but lay people. When you begin to understand, you become aware of the issues that are underlying, the systemic issues that are underlying the problems that we see in the United States.
Mm-hmm.
Once you recognize those, then there are small changes you make in your everyday lives that contribute to changing the way this country has been operating. So small things such as understanding that you have your own bias.
Mm-hmm.
All of us do, regardless of what our outer covering looks like. We're human. And those biases were formed whether or not we are aware of them from the time we were born, right? And that's just human nature. So to recognize that you're not a perfect human is key. So once I recognize that I'm not perfect and I recognize that I do have biases and to be in touch with whatever they are, then I begin to understand that that does affect how I present myself in clinical practice. It does affect how I treat other humans. So we all go into healthcare believing that we can make a change and we can contribute to the betterment of society. And we all do want that. But there, somewhere along the lines, we're conditioned to believe that we're a little bit better than others because we know a little bit more. It's just the nature of the beast. What we do need to begin to realize is that although we have education, that does not make us better than anyone else. And that when we come to the bedside, we look at that person as another member of our family, regardless of their outer covering. Would I not provide all options to my family, my cousin, my brother, my sister, good or bad? Would I not do that? Or would I tell them all their options and tell them that, and let them make that decision on their own and respect them as humans? Right. Would I not want to understand if, regardless of the medication or the treatment regimen that I'm providing for you, and you consistently return to me and it's not the intended effects are not what I'm seeing, would I not want to delve deeper and figure out, is there something else that I'm missing? Or is my time so precious and am I so superior that I really could care less whether or not the treatment regimen that I supposedly know should be beneficial to you is not really working for you? Wouldn't I delve into what other aspects of your life may be affected by this treatment regimen, right? So you begin to, when you start to realize that you're human, you have faults, and everyone shows up in a space with imperfections, you begin to really change the way your practice begins to change because you look at other aspects of the humanness in front of you other than them being a sum of parts. Mm-hmm. You realize that they're affected not only by what's physiologically manifesting, but also their environment, their home, their family, their communities. And it's a slow process. It's going to take a very long time for us to get to the point where we really treat individuals and families holistically. Mm-hmm. But it is something that we can start to do. And it's not hard.
Right. Yeah, I agree. I think it's the basis of nursing. I think it's what we do best as nurses. And unfortunately, and I think, this is my very small experience, but I feel like as a profession, in an effort to legitimize ourselves, we've pulled away from that holistic standpoint more toward, a medical model, which is based on illness and, whatever is presented in front of you at the time. And I feel like we've done ourselves a disservice that, coming back to that very holistic piece of it is what we do best and what makes us so great at all the things that we do.
Yeah, you're absolutely right. Absolutely right. Uh, it- Understanding that nursing and our subspecialties that we are in nursing, myself being in midwifery and you're being in anesthesia, the philosophy and approach to healthcare is different than in medical school. Doesn't make it any better, doesn't make it any worse. It's a different philosophy.
Right.
But the understanding there is that to understand differences and appreciate differences. So it even transcends into how we're educated. We've been taught to believe that medicine is the only way, right? That going to a physician is the only way. That's the only option, and doctors know it all. And I'm not doctor bashing because I'm a child of one. That's the only way in the United States. But and not understanding and appreciating all the other members of the healthcare team that also uplift and support medicine, right?
Right.
And once you do understand that philosophy and understand that approach and understand that everyone contributes to the betterment of health, then you really start to make change and affect change.
Yes, I couldn't agree with you more. I just want to kind of talk a little bit about some of your policy work that you've done, and what you're doing, looking at the big picture of things.
With policy work, so I'll start with, because I've done more of that in New York State, so I'll talk a little bit about New York State and the policy work that I've been included upon and been honored to be involved in. And when New York State's Maternal Mortality and Racial Disparities Task Force, being involved in that was such an honor because we really, as a task force, we were able to really delve into multiple aspects that affect maternal mortality, from community on up to our established hospital systems, right? And look at the multiple components that are involved in affecting maternal mortality and severe maternal morbidity. And so we were charged with coming up with recommendations. So there were multiple recommendations, but we came up with the top 10 that we wanted really to work on in the very beginning, to policies that would start to begin to affect change. And so the top one was, in New York State, we did not have an established maternal mortality review board that was statewide, that was protective, that really delved deep into each maternal mortality review case and came up with de-identified recommendations that could affect policy change. And so what we did was rallied for that, and we lobbied for that, and we were able to get that put into a law, put into the governor's budget and law, that we would have a maternal mortality review board that would be funded for years to come, right? Because you need funding behind that, or else any little task force or anything else would then disappear or go away once the funding runs out, right? So we wanted that to be sustainable. So that was the top thing. And then to establish a method in a repository for us to utilize this de-identified information that we would get from these persons that lost their lives during pregnancy and birthing, and do them justice by utilizing learning from their deaths and being able to really affect policy change. So that was the second thing. Then we also looked at, there are many folks in New York that really want to join the healthcare workforce, different aspects, to be physicians, to be nurses, to be midwives, to be healthcare workers, to psychologists, sociologists. And they're hindered because there are barriers to education, especially for Black and brown members of our society, right? On immigrant members that may not have the access to money and to higher education. So we wanted to make a pathway to make it easier to diversify your workforce, right? Because study shows that when you have culturally congruent members of your healthcare workforce, patients seem to fare better, right?
Right.
So in order to diversify that, how do we do that? So one of the ways is to create more scholarships for your city colleges and your city universities that would target your marginalized members of your community, your Black and brown and immigrant members of your communities, in order for them to have a pathway to access a higher education. Mm-hmm. Also, saying that members that are intended to go into healthcare, then for those that are already in healthcare and maybe paying off multiple student loans and may want to advance their education, but they're working, providing for a family, multiple jobs, have a pathway for loan forgiveness so that other members of your community that are already in healthcare can continue to advance their education and their ability. So to provide loan forgiveness for people that want to become physicians, nurse, midwives, CRNAs, mm-hmm. get a PhD in psychology or social work, mm-hmm. in order for them to continue to move up the ladder, right? Because then that also enhances your society, increases your workforce, increases your access, enhances your society, right, as a whole. And also, there are multiple points. So midwives are reimbursed in New York State at 85% for Medicaid, at 85% of the amount that a physician is reimbursed for the same exact care in billing. So one of the other recommendations was to increase parity in care, parity in reimbursement. So if you have parity in reimbursement, then you also say it's a message to society and to members of that workforce, we value your contributions to the healthcare team if you have parity in reimbursement for the same care across the board. So those are some of the recommendations that we came up with in order to start to begin to combat maternal mortality and racial disparities. We also wanted to have bias and cultural humility training for members of the healthcare teams, from your suppliers to healthcare on up to your CEOs and your presidents in your established healthcare teams, because we, like I said before, some people think that they're perfect. Some people think that because they have more education, that makes them better than other members of society. But there's a lack of recognition of bias. And this is something that each human has to learn. It was part of my journey of learning my own biases. But I can tell you that even becoming aware that I do have bias and becoming aware of what they are, I know for a fact that made me a better human, which makes me a better provider. Mm-hmm. So to have bias training and cultural humility training for all members of your healthcare team, and also to move that to education. So not only when they're already providers, but to start that from when these people are in school. So, and then it led to the conversation of, well, in what aspect and what level of their education do we begin to start to talk about bias and cultural humility? And one would argue it goes all the way back to elementary school. But for us, really, to really have a realistic goal, we talked about beginning at the high school level where you talk about bias and cultural humility, and then really target, to start in high school and really target when you're in higher education, for those, especially for those members that are seeking to major in healthcare. So that's the governor's task force for maternal mortality and racial disparities. I already talked about the Maria abstraction form with the CDC, and now for the governor's task force related to COVID, opening up and the recognition that not all birthing people want to birth in a hospital, and understanding and valuing that members of our community would like alternative areas in which and places in which they would like to birth. So, and to incorporate that into those aspects into your healthcare landscape, such as birth centers, home births, those types of things.
Mm-hmm.
Yeah.
Yeah. How are the birth centers dealing with the pandemic?
So in New York, at least, we have 2 supposedly in the boroughs and 3 in the state.
Oh,
and
wow.
So, yeah. New York State is very unique in that there really has not been birth centers in New York State. And we're trying to change that.
Right.
Because there's been a demand, there has been for many years a demand in having birth centers. They're inundated. They've been overwhelmed with the pandemic.
Mm-hmm.
They are having to, unfortunately, turn patients away. Of course, this is anecdotal information of birth centers. And then who's more affected, even more affected, are your home birth midwives, who are normally get 1 to 2 calls possibly a month. They began to receive over 100 calls a day for women wanting to birth at home because of the fear of going into a hospital and possibly contracting COVID-19. So again, underscoring the disparities we already have, we have persons that don't want to necessarily birth in a hospital. How are we ensuring as a healthcare workforce that those members, we address the needs and desires of those members of our community that would like alternative options to where they birth and with whom they birth? Right?
Right.
So that's also what we're looking at, yes.
Yeah, another huge challenge. Everyone wanting to stay far away from the hospital.
Now, that's not to say hospitals are a bad place, and please don't get me wrong.
No. I should have clarified. I meant during the pandemic when you know that there's people with COVID in the hospital. So that I'm sure that is another advantage to going to a birthing center, that you're not going to be near anyone who's sick, or at least that's what you're hoping for.
Yes.
Well, I want to be mindful of your time. Thank you so much. I really appreciate you speaking with us today. This has been fantastic.
Thank you.
It's all such really, really important work that you're doing, and I hope that we can help to get it out there.
Yes, absolutely. Thank you very much for having me. It's been wonderful talking to you. We could continue the conversation for hours, but in being mindful of each other's time, this was great. Thank you.
Amplify Nursing is hosted by Dr. Angela Rosa DiDonato and Marion Leary, and produced by the University of Pennsylvania School of Nursing, with special thanks to our Department of Information Technology Services for their assistance. Music for the podcast was created by Harper Leary. The podcast is made possible by the Krista and Rich Pinola Fund for Innovation in Nursing.
Follow us on Twitter at Penn Nursing. Until next time, keep pushing over, under, around, and through. We want to thank you for listening to the Amplify Nursing podcast. and remind you to subscribe to the podcast on iTunes, Google Play, Spotify, or wherever you enjoy your podcast listening. And if you can, please do us a solid and rate and review us as well. It will go a long way in amplifying our episodes.